nice webinar, I think, about pelvic pain in men. It's a pleasure to be here and to speak to you, and thanks to Onno and Novaquare for inviting me and giving me the opportunity to talk about you. We had a webinar in May this year about chronic pelvic pain and sexology, and this time it's about pelvic pain. So there's going to be some overlap and going to be some repeating, but that will never hurt. Well, this is my life saying I got from Leonardo da Vinci, who says that realize that everything connects to everything else. And that's really important to realize when you're working with patients, and especially also with male patients with pelvic pain. So a little introduction, and then I'll tell you something about pain. I'll tell you something about males, and then I'll tell you something about pain and males, and ending up with care and males. So let's start with pain. When we talk about pain, then we stick and we always start with a definition. And pain is just a spontaneous construction of the brain in response to perceived threats and focused on healing. And these are the most important elements of pain. Realize that it is made by the brain always, because the brain perceives threats and the brain always is focused on healing. Whatever it does, it is focused on healing. Since about 2 years now, we have the ICD-11, and this is the first ICD version that has chronic pain as a separate definition, and it divides it into primary and secondary pain. And I still think that's a good division, because first of all, when a patient has chronic pain, you're looking for a cause. If there's anything wrong that can explain the pain. And if so, then we talk about chronic secondary pain. If you can't find any cause, we're talking about chronic primary pain. So secondary means that pain is a symptom, and primary means that pain is a disease. And when you look at the different other terms in this whole pain business, we have the different types of pain. And when pain is a symptom, we talk about nociceptive pain, which means that there is sick tissue, so there's an inflammation or there's a trauma, or there's neuropathic pain, which means that there is sick nervous tissue. Tissue can be having a trauma, but it's not always very clear what's wrong with the nervous system, but we know it by the kind of pain that people are reporting to us. When it is a disease, so in the primary pain, we have the nociplastic pain, and that's a bit of a newer definition, 2017, which means that nociception has changed. So in the periphery, in the tissues, the nociceptive function has changed. And less or more, you can say that when there's no nociceptive and no neuropathic pain, then you're talking about nociplastic pain. And if you think, what about central sensitization? Well, of course, it's still there, because it says something about what the brain does with the signals coming from the periphery. But central sensitization can play a role also in the secondary pain. So it's a bit more a bigger one, so to say, which is applicable to all the different types of pain. So this is the simple scheme about what our brain is doing. And our brain is transforming incoming information into meaningful action. That's what the brain does. So the information is coming from the different organs and skin, etc. And the brain is working on it and then decides to a certain action. And it always does that because it wants to protect us. That's the function of the brain, protecting us. And this is influenced, the decision of the brain, by the environment, the feeling, the past, etc. So what I always tell my patients is it is like your cell phone. There is an indication of the battery percentage, and it does nothing more than telling you how far your battery is charged. And then you're going to think, what time is it? Where am I? What are my plans? What am I going to do? And based on that, two types of information, you decide whether or not you're going to charge your cell phone. Your cell phone will never say you need to charge your phone now. Never. because that's not the function of the cell phone. That's your decision, not that from the cell phone. So the biggest mistake in the whole pain business is that nociception leads to pain. And now we know that nociception leads to inflammation to the brain, and that leads to pain. That's really, really important to realize that always when you're talking about pain, the brain is involved. And on the same information, nociceptive information, the brain can always also decide not to make pain, or the brain can decide to make itching feelings. It's just a decision of the brain, and it has no direct relation with the information coming from the peripheral tissues. And on the other hand, if A doesn't necessarily lead to B, it means that if there's B, it doesn't necessarily mean that there's always also A. So normal information from the periphery, from the tissues, can also lead to a situation in which the brain decides to make pain. And the brain only does it because it wants to protect us. And again, it's all influenced by the environments, the feelings, and the past. And then one more, which is also a very important one. The brain is the organ that takes the action. And the brain can take action by giving us a certain feeling, by giving us certain thoughts, ideas, etc. But the brain also influences our peripheral tissues. And the brain is capable of, via the nervous system, to induce inflammation in the peripheral tissues. Nerve endings can make inflammatory soup, as it is called. A lot of substances that are made by the nerves and lead to inflammatory reactions in the tissue. And that's not that much a problem, because inflammation is a cure process. We need inflammatory reactions to be cured, the tissue to be cured. So it's a protective mechanism of our brain. And then one very special item which has gained a lot of interest in brain research in the last 5 to 10 years, that's the predictive processing. And I think I talked about that last time, but I really want to show you, because that's a very important mechanism when you're talking about pain. What does it mean? Predictive processing is the idea that our brain is actively predicting upcoming sensory inputs. So the brain is predicting what input comes from the peripheral tissues, what you see, what you hear, what you feel, etc. And it does it instead of that it's only passively registering. So if you're doing things, the brain predicts what will be the information. And it is important that the brain is right. Because when we do a little thought experiment. If I put a blindfold on you and I say to you, well, here is a slice of apple, and put it into your mouth. But what I really do is I give you a slice of peach. Wonderful peach, very tasteful. But what's happening in the brain? I say a crunchy slice of apple. That's what the brain hears. And the brain has an expectation. And what it tastes is a soft slice of peach. And this means that prediction is falsified. It's soft and moist what comes in. And that was not what the brain was expecting. And then the brain goes into a kind of an alarm situation, because the prediction isn't good. Prediction is falsified. And then the brain adapts the information and thought, well, if it is an apple and it is soft and like this, it must be a rotten apple. So the brain says you're in danger. You're eating a rotten apple. That's not a good. I'm your protector. So I'll take action. And it gives you a rotten taste. Even though it's a very nice peach, the taste will be of a rotten taste, because that's how the brain is protecting you. And there's a good reason that you might spit it out. although it's a very nice kind of piece. And this links to what we know as nocebo and placebo, which means that if you say things, if you do things, and it's the meaning what you give with what you're doing that leads to the ultimate results. And a nocebo is a harmless event or comment that causes damage because you believe that it's harmful. And we do see a tremendous lot of nocebos when you hear people talking about pain. Even caregivers often use nocebos, like saying, what you have is a difficult problem. It sounds with compassion, but it isn't. It's a pure nocebo. The same with what is shame, you're still in pain. It doesn't work. The brain of that patient who you're talking to is going into the alarm phase. And the same for like that does not sound well. And what we want is to change to the placebo, which means that what you say or what you do has a positive effect, and you think that you feel it as good because you think it's good. So use positive language. Whenever you're talking with a patient, use positive language, no matter how you do it, but remember that it should be positive what you're saying. And repeat, repeat, repeat. And I also teach my patients to do so, to talk with their brain and speak out loud, to say to their brain, thank you for informing me, thank you for protecting me. I feel the pain, I've heard your signal, but I'm now doing something else, and I'll come back to you afterwards. If you like this kind of stuff, then you should really consider to read this book, The Painful Truths from Monty Lyman. It's all about scientists. It's all about science. Sorry. It's all about science, and he has a lot of brilliant stories. For instance, about the predictive process. Okay, males, because that was the main subject for this webinar. And males are a very special kind of people. I'm one myself, so I may say it. And that means that we have to look at the male pelvic anatomy. And when you look from the outside, it's not that much different from the female pelvic anatomy. You can see all the muscles that you also find in the female anatomy around the anus and around the vagina in the female, and here around the base of the penis, the ischiocavernosus and pelvis muscles. But if we go inside, there's a lot of difference. And I don't know how to say it, but the male anatomy is a bit more challenging than the female anatomy because the organs have more relations and different relations to each other. And when you're looking here at the left one, you see the bladder, you see the prostate, and you see the urethra. And here you see what's called the urogenital diaphragm, which is a part of the pelvic floor muscles, like the pelvic diaphragm. So here you nicely see the form of the pelvic floor and how the organs are resting on it. On the right side is a little bit more in detail, and you see the close relationship between the bladder and the prostate. And the prostate is the male organ that's so specific in this region for the function of not only being, but also for sexual function. And anatomy of the prostate is always a bit difficult for many because the relation between the urethra and the prostate is easily understood when you look inside it like urologists do, but here you see it nicely on this picture. The urethra is going through the prostate, then it goes through the pelvic floor, and then it goes to the outside. A little bit more in detail with the bladder and the prostate. And you see here on the left, the front look, this is the bladder, it's cut open. Here you see the ureters coming into the bladder and delivering the urine from the kidneys. And here you see the bladder neck. And then again, you see the urethra. This is the prostatic part of the urethra, and the prostate is lying around it. Here is the bladder neck, which has a sphincteric function, and here is the external urethral sphincter combined with the pelvic floor muscles. On the back side, it's even more complicated because here you have the ductus deferens, it comes from the testicles. It's delivering the seed. And you have here the seminal vesicles, and they're all opening into the prostate, into the area of the prostate, and it is combined with prostate fluid, and that's what's called the ejaculation fluid. And here you see the pelvic floor, and here you see the Cowper glands, which make the fluid that comes out of the urethra when you start getting sexually aroused. Including the penis and the testicles on this side, we see that, again, you have the bladder, you have the prostate, the pelvic floor, and here you have the penis. And here you see the continuation of the urethra through the penile shaft until the end, where it ends in the open air. And urine is passing from the bladder, prostatic urethra, to the pendular urethra, to the outside. And next to the urethra, which is also inside the corpus spongiosum, as it is called, to protect it, you see the corpora cavernosa. And these are the erectile parts of the penis. I'll show you that afterwards. And if we're looking at the organs in a complete view from the pelvic area, so not only the bladder and the prostate and the genitals, but also here you see the relation with the gut, with the rectum, and again with the pelvic floor. Of course, there is a lot of blood supply to the pelvic area. The organs need their blood, and especially in male for the erection. The erectile function is a pure function based on blood vessels. And the blood almost completely comes from the pudendal artery, and you see here to the penis, to the scrotum, and to the perineal area. All this is supplied by branches of the pudendal arteria. And like I said, we're talking about male, so a little bit more attention for the penile structures. And what you see in the penile structures is that it's all on the dorsal side of the penis. That's where it's all happening if you're talking about arteries, nerves, and veins. And you see there are circumflex branches going around to supply just the tissue of the penis. And if you look at this here on the right side, again, you see here in the dorsal complex with the nerves, with the artery and the veins. And one more important is the deep artery. And the deep artery is especially for the erectile mechanism. That's an important one to realize. In both corpora cavernosa, who are interconnected with each other, you have a deep artery. And here you see the urethra, which is protected by the corpus spongiosum. Because when there's an erection, it gets very stiff here. So the urethra needs to be protected by that corpus spongiosum. This is a little bit about the nerves, and I really only want to attend to on the pudendal nerve, which is a very complicated but complex nerve, but it also has sensory fibers from the penis. Pudendal nerve, we know that pudendal neuralgia. This is a nice drawing where you see the pudendal nerve with all its branches to the genital area. And here you see the two areas where the nerve can be pressed, and which may lead to pudendal neuralgia. And if we're talking about pudendal neuralgia, it's also in the male, it's an important one. I have the idea, we know it quite well in women because of giving birth, etc. But of course, males do have a pudendal nerve, and they do have quite comparable anatomy that could lead to pudendal neuralgia based on pudendal compression. And it's important to look at the dermatomes, where you can see that the pudendal is here in the central part, with the in the male, the dorsal part of the penis, the perineal part, the rectal branch, and the coccygeus. So this central area is from the pudendus, and you see that's quite comparable with the female anatomy, talking about these dermatomes. Again, one thing very special for the male is the relation between the prostate and the rectum and the neurovascular bundle. And the neurovascular bundle is important because that's for the erection, but it's also for the sphincters in the urethra. So the pudendal neurovascular bundle here is important for both continence and erection. And what I show you here is a drawing that is made of for illustrating what we do when we do a radical prostatectomy. So you can see here the big red signs. This is the area where we operate, where we do a radical prostatectomy. And you see that the neurovascular bundle is so much in the vicinity of that prostate and of that area where we have to operate. So you can imagine that after radical prostatectomy, patients do have incontinence and do have erectile dysfunction. When we're talking about the sexual function, the two main items that we need to address, which is the erection and the ejaculation. Orgasm is a process in the brain based on information coming from the genital area, but also from many other areas. The erection is a parasympathetic phenomenon, so it's based on the parasympathetic nervous system, and the ejaculation is sympathetic and somatic. And here again, you see the most important nerves, the hypogastric nerves, the pelvic plexus, and the pudendal nerve, which are involved in all the areas and all the instruments that you need to get an erection and to get an ejaculation. We know that ejaculation and the fact that the ejaculate is coming out at a high speed is almost completely done by the pelvic floor muscles. So there's a big relation of having an ejaculation and your pelvic floor muscles. Okay, a little step outside, but important. You can only improve what you can measure. I believe that it's really important still to measure the pelvic floor function, not just to say, oh, well, he has that complaint, so it could be a pelvic floor problem. At first, that's okay. If urologists would say that, then I would be very happy, and then referred to a well-trained pelvic physiotherapist to do a diagnostic investigation and to come up with a diagnosis about what the pelvic floor situation is. So you can use your finger and you can use the MAPLe. You can use your finger to measure pelvic floor muscle activity. You can diagnose pelvic floor muscle status like the tone, the hypertone problems, the inactivity or coordination problems, whatever. Important to control the instructions. It's absolutely necessary to do so. If you give an instruction about the pelvic floor muscles, you need to control it because you can never be sure that they are doing what you say, and to palpate local abnormalities. Well, why use the MAPLe? Because it gives a 3D representation of the muscles, which is a lot of extra information. It also gives less exposure to the genital region, which might even be more applicable to the male, because the male genitals, if they're lying on their back, are always a bit lying in the field. You have to put them away. You can ask the patient itself, of course, by doing it. The visual feedback to the patient is important, and the information is much more specific. When you look at the literature about male pelvic pain, male pelvic floor pain, and the MAPLe, there are some articles. There has been done a retest, reproducibility in men, and what they say especially is that a strict protocol is needed. So you have to strict protocol in how you're using your MAPLe in men with LUTS to have a good retest reproducibility. That's important. So work with a protocol. There is also a study about pelvic floor muscle function in men with and without pelvic floor system. And they say that there is no clear association between muscle dysfunction and the number of symptoms. And dysfunction levels are highest for the puberrectators. So they say we need further research. And doing research in this area is not that easy because pelvic floor symptoms in men need to be divided into the different ones, I believe, to do a study which gives you more information. And the last one is exploring pelvic floor muscle activity in men with lower urinary tract symptoms. So this is not all the pelvic symptoms, but only the lower urinary tract. And they say, I was still a bit surprised at that time when it was published, that pelvic floor muscle activity and LUTS severity appear to be unrelated. And I think it's important what they also say, that don't think about it and say, oh, well, I don't need to do a pelvic floor examination. You still should need to do it because we see a lot of improving symptoms of LUTS in patients going to the physiotherapy. Okay, pain in males. What about specific pain in males? If you look at literature, you see that there's much more attention for female pelvic pain than male pelvic pain. It's about a threefold of articles that are published on the females. And these are the three important parts of pain in the male: the prostate pain, the scrotal pain or testicular pain, and the penile or bladder pain, urethral pain. So in men, we have the 4 P's of male pelvic problems: pee, poop, penetration, and pain. And when we look at prostate pain, talking about diagnostics and additional diagnostics, you should do a clear anamnesis, you should do a clear history. You can use validated questionnaires, especially the NIH CPSI is a good one. The IPSS is just for the LUTS. Additional diagnosis in every patient with problems in male pain. We do a micturition list, we do a uroflowmetry, and not in every patient, but sometimes we do an ultrasound. This is the uroflowmetry. I think you're familiar with that. This is a normal one. This is a flat one, which can be related to problems with prostate or the urethra. And this is a one that you will recognize from pelvic floor dysfunction, a dysfunctional flow. Scrotum pain, what we do in diagnostics, you always should do a physical examination because you want to know if there is something wrong that can explain the pain. And especially in the scrotal pain and the testicular pain, it's important to be sure that there are no big problems, and especially tumors in the testes. Then they're not the most seen cause of pain, but you need to find them. Ultrasound is not advised in guidelines because we know that it's almost always normal, more than 80%. You can use it to reassure a patient that there's no tumor, but on the other hand, you will always have the risk of finding something that's not important, that does not explain the pain, but then the patient knows it. So you have to talk about it, and patients often said it should be removed because I'm convinced that that's the problem. Anorectal pain, the levator ani syndrome, is chronic or repeated pain in the anus, at least 30 minutes. And the most important thing is the diagnostics with stretching the puborectalis muscle. If there's pain, it's a levator ani syndrome. If there's no pain, it's called unspecified anorectal pain. And a different one is the anodyspareunia. It's not a brilliant term, but it is what it is. That's pain during anal intercourse, and that's especially used in the group of MSM, men having sex with men. It's important to ask if patients talk about pelvic pain, male patients, if they have anal contact, if they have contact with other males. The genital sexual pain. Genital pain is pain in the penile shaft, which could either be spontaneous if they're just resting or during erection. That's an important one to define. Pain in the urethra is often reported at the external meatus. And we know that it has a kind of association with prostate pain and bladder pain. Or when patients have an overactive bladder, they can also say, I have a problem at the end of my penis. That's where it hurts, that's where it irritates. And we think that it has something to do with the nerve supply, like I showed you. It's a kind of an antenna of the bladder. And then we have the sexual pain, and one of the biggest in sexual pain is the post-orgasmic pain, and that's really a big problem for male patients because they have an orgasm. That's nice, and directly after they're going into very much of pain, and you can imagine that leads to having problems of getting an orgasm because the brain says, well, we're not going to do that because that will give a pain. And it has a lot of influence on sexual pleasure, on sexual function. I'll come back on that later. Well, this picture is familiar to you. We talked about the deep artery. If you look at the deep artery more in detail, then you can see that here's the deep artery coming in. Blood is coming in. Here are some cavities in which the blood is transported to the outgoing veins, which remove the blood from the corpora cavernosa. And if you're going to an erectile state, the first thing that's always happening when you get sexually aroused is an increase in the blood supply, an increase in the blood flow, which puts the blood via the deep artery into these cavities. And they fill with blood. That will give a kind of pressure, and that will lead to a diminishing of the outflow. It still is going around. It never stops. Blood flow never stops, because then you're going to have a dead organ. And that leads to a filling of the corpora cavernosa, and because the wall is stiff and it is fluid, so you can't compress it, that leads to stiffening, and that leads to a change in the position of the corpora cavernosa, so it gets straight, and that means that the penis is lengthening. It not always goes that much up. That differs between men. So erection is about blood flow. That's what it's all about. Problems that we have in the erectile tissue is especially the morbus Peyronie. You can see it here. It's a plaque. It's a stiff tissue. It's a kind of formation from which we still don't know why it happens, but you can often see it's a kind of scar. That's what it best feels. It leads to a curvature, because when the corpora are functioning, are filled, this one cannot lengthen. So that leads to the curvature. It could be to the side, could be to the dorsal, or could be to the ventral side. Doesn't mean. And this also often leads to pain. And because the curvature and the pain, it might indirectly lead to a erectile dysfunction. Another quite simple but important one in genital pain and sexual pain is the phimosis. It's the foreskin which cannot be pulled back over the glands, and that can also lead to pain, especially in erection. Patients don't have any problems when in the flaccid state, but when they get an erection, then the pain starts, and that may indirectly again lead to erectile dysfunction. This is a bit difficult. I'm not going to say all about it, but this is about orgasm and ejaculation. And you see orgasm is in the brain, so you can imagine how the orgasm is influenced by the pain. And the ejaculation is important. Like I said, it's important because of the muscle function. There are two processes. The one is the loading of the ejaculate, and the second is the shooting of the ejaculate. And again, you see that the pudendal nerve is playing a very important role in the ejaculatory process. And last but not least, the pelvic floor pain. I'm not going to say too much about it because you're often quite familiar with it. It's important to look at a broader area and do an internal examination of the pelvic floor. Trigger points, I still think they're important to look for. And in the male, when you have trigger points in the abdominal muscles, 74% has pain in the penis. And for the puborectalis, that's even larger. It's 93%. So there's an important relation with the penile function. What do we do in prostate pain? Well, we can use alpha blockers, but only if patients have complaints for less than a year. You can use antibiotics. Be sure to continue it for 6 to 8 weeks. And afterwards, do not repeat. Patients often have a better feeling and say, I want antibiotics. And then you end up with giving antibiotics every 1 or 2 months. Don't do that. Scrotum pain, there is a relation with surgery, especially with the vasectomy. So you should give good information in a positive way about pain after the procedure. And in the inguinal hernia repair. And if patients are at an increased risk of chronic pain because they have other pain problems, for instance, you should consider doing an open inguinal hernia repair instead of laparoscopic. Anorectal pain in therapy is a bit more easy because we have good studies and we know that pelvic floor biofeedback is first choice therapy. That's easy. That's very well measured. Another one is the botulinum toxin in the muscles. It's used in female, but we often use it in male, and the effects are really good. So consider it when you feel that there is a very high tone in the pelvic floor muscles to do it, and you're just breaking the chain of the hypertonicity. And it's utmost important that you continue your pelvic floor therapy after having done the Botox, because patients often say, oh, well, okay, my pain's well, I'm having any pain at all, thank you, and never see you again. And that's not good, because then they will come to you back after 3-4 months and say, well, everything is as it was before the Botox. So continue with your pelvic floor muscle therapy, because of having broken the chain, you get the opportunity to work on the pelvic floor. Well, the same is true for the genital and sexual pain. And of course, we need here to consider sexological counseling. Refer to a sexologist to talk about the erectile dysfunction, which is almost always indirect result of the pelvic pain. And again, look for causes, and if they are treated, that's like the femur cyst. And also in the morbus peyronie, you should consider to treat the plaque. You can do that in 2 ways, by doing an operation. And what you do in the operation is, simply said, giving the same situation on the other one. So in this situation, by some sutures, so that pulls it right. It always gives a little bit of shortening of the penis, about 1 to 1.5 centimeter. Discuss it. Shockwave is used increasingly in treating peyronie. The research surgery, the results in the research are not completely convincing to me at the time, but maybe that's a good one. Femurs is important. What we do is always start with local corticosteroids, class 4. That's important. It often helps. It will be okay. And if not, you can do a foreskinplasty. That's what you see here in the blue one. You make an incision and you resuture it again in a different way, which gives more space here for the foreskin. You can consider it. It does not always work. If it is too much or too much scar, it will not work because you need good tissue. And the other one is the circumcision, in which you completely remove the foreskin, so the glands of the penis will become, as I often say, naked. And this needs to be adapted by the patient. Again, in the brain. The brain's getting very much different information from the glands than it has before. So it needs to be adapted, needs time. But if it's very narrow, you don't have any choice just to remove the foreskin, but always consider if there are any other options. And then the latest one, I didn't call it, but it's important to mention, is the short frenulum. The frenulum is this little band here between the meatus of the urethra and the penile shaft. We have 2 frenulums. One is underneath our tongue, and the other one is here. And what's going on is, if it is too short, it gets a bending of the glands of the penis, and this can also lead to pain in erection because it is stretched. And what you do is simply incise the band. It's a very simple operation, and I really don't know any contraindications. If it is short, just do that simple operation, and then it will lead to a lot of pleasure for the patient. The pelvic floor pain, of course, pelvic floor therapy, that's the main botulinum. I talked about it, some specific options based on the complaints of the pain. And if you are a pelvic floor physiotherapist and you treat pelvic floor pain, remember that there are also general pain management measures that you can take or work together in a multidisciplinary team with a doctor who can give medication, especially for the neuropathic pain part, work with a psychologist who is experienced in treating patients with pain in special. And in Holland, pelvic floor physiotherapists do use virtual reality as a general pain management, adding it to the pelvic floor muscle therapy. One of the latest developments in treating pelvic pain and other sorts of pain is the INDIBAT, the CRMRF, the capacitive resistive monopolar radio frequency. It's a machine that gives a radio frequency at 448 kilohertz, and when you put that into the tissue, it activates the biostimulation, it increases circulation, and it produces hyperactivation. So this is a kind of healing process that the brain is also capable of doing. This is comparable to what the brain is doing when it gives types of certain inflammation. What are the indications? Scars are reacting in our experience quite well. Scars after operation, an overactive pelvic floor, persistent tailbone pain, and we do see quite of good results on the groin pain and the testicular pain. This is an important area that has to be looked on further, and that has been done already. In 2022, it was looked at the treatment of chronic pelvic pain syndrome, and they did a mixed group of male and female, with a little bit more female, sorry, about 68%. And what they did is they did either a combination of physiotherapeutic techniques with the INDIBAT treatment, or only the physiotherapeutic techniques adding up a sham treatment. So they put on the plaques of the machine, but they didn't give the signals. This is called that's what sham is meaning. And they said that they demonstrate superiority in decreasing pain and improving quality of life. So it seems that in a sham controlled study in this group that the CRMRF is really adding up something to the treatment of chronic pelvic pain syndromes. So it's worth studying it further, and again, a little bit more specific for the different types of pelvic pain, especially in the different areas, to get more information on how useful and how well it is doing. And here again, you see it in the graph. The blue ones are the treatment groups, and this is the control. I was looking a bit at this because it seems that in the treatment group there was a bit higher fuss of pain at the start, but I think it needs further study, and that's what this study has opened up. Okay, we're ending up with care and males, and also in males, it's important to talk about pain and to talk about the real nature of pain. And when I look at my patient group, I see that male patients are handling pain and ideas like this maybe a little bit different than women. So it's still important to have a good look at that patient who is sitting in front of you, and making clear things like that pain is more what the brain thinks of your state of health than that it is a reflection on injury. And this is what I talked about in the predictive process, etc. And talking about male and sexual dysfunction and pain, there's always the question of the patient, is it between the ears or between the legs? And male patients more often say, well, it's not a psychological problem. Patients with an erectile dysfunction say, no, it's my penis, there's something wrong. It's not between my ears. I love my partner. I'm happy. I want to have sex, etc., etc. So there must be something wrong between my legs, which could be, of course, especially with pelvic floor muscle dysfunction. We seldom see really somatic causes of erectile dysfunction. So this is a good discussion to have. This study from Sweden, from Ida Flink, which is a psychologist dealing with pain. She's a member of the European Guideline on Chronic Pelvic Pain, talking about the role of psychological factors and sexual dysfunctions. And she found, which is also a bit remarkable, that premature ejaculation was the only sexual variable that differed between men with and without pelvic pain. So there is not such a strong relation between pelvic pain and sexual problems. And that's the same as they say in their conclusion. They see elevated levels of psychological distress and to some extent sexual dysfunction. So the general psychological factors and changes and complaints were much more clear than the sexual dysfunctions. Important to talk about further. As you can see, that this is all connected to sexual activity. So what's the relation between male pelvic pain and the sexual dysfunctions like erectile premature ejaculation, lack of desire, arousal problems? And we really don't know very well how that is. And what we think is that two mechanisms are important. First are the coping mechanisms. How do you deal with your pelvic pain? And the pelvic floor muscle functions. And these are thought to influence the sexual dysfunctions. And the bigger thing is, and the glad thing is to say that you can handle coping mechanisms. You can deal with coping mechanisms. You can treat them with cognitive therapy on changing their coping mechanisms. And you can change their pelvic floor muscle function, dysfunction, with a pelvic floor physiotherapy. So both of these things, and that's the psychologist and the pelvic floor physiotherapist, which do have a main part in treating male patients with pelvic pain. These two types of caregivers should be included in treating patients. And then always there's the other one. What does sexual dysfunction do with male pelvic pain? And again, we don't know. But again, we can work on it. And we can work on it again with the coping mechanisms, because you have an erectile dysfunction and you do feel some pain that may higher up your pain. And the other one is the sexual relations. And they also can influence your pain. If you have erectile dysfunctions and some pain and you have a good relation and your partner can help you, that might also lead to a diminishing of your pain. This is pure sexology, and this is wonderful. This is what I love about sexology, when you're talking in two people having sex with each other. And these couples are sitting opposite to me on my desk when I'm doing sexology every day. And I like to see the process because you can easily work on it. And it's often very helpful to work on the process that you're seeing here. And it simply starts with having a less good erection. And what the women is thinking, oh, his erection is not that good. He doesn't find me exciting. He does not get sexual arousal from me. And this might lead that she is getting into defense, and which makes that she's using her pelvic floor muscles, getting pain during intercourse. She's saying that to her partner. When they have intercourse, the partner thinks, oh, well, I have to speed up because we can't have intercourse for a longer time. This leads to the fact that the male partner wants to get an orgasm and an ejaculation. So this leads to a premature ejaculation in the male patients. But after sometimes having a premature ejaculation, the sexual interest is diminishing. This is not what he really wants. It's not what he really likes. So he doesn't show to his partner that he is sexually interested in her. And then she's like, well, he doesn't love me anymore. And well, she might end up with saying, well, okay, this is it. He doesn't love me anymore. See what we can do with our relation. But she can also go in an active role and display very seductive behavior. And then the male patient thinks, oh, whoa, what does she want now? I cannot deliver what she wants. And that leads to a fear of failure in the male. And you can draw an arrow from the fear of failure here to the erection, because fear of failure will again lead to more erectile dysfunction. So this is a kind of ping pong, a kind of yin yang, whatever you want to call it, which is almost always happening when two people are having a relation and there's something going on like erectile dysfunction or pain. And this is the model of sexual motivation, and there are two things that are important. Here is pain is very disruptive in this circle of the sexual motivation. So this is an important one. There is sexual stimulation, but by processing the sexual stimuli, pain could be a very negative factor. And again, here you see the understanding partner. If you're dealing with sexual stimuli, if you want to receive it or not, and really leading to sexual stimulation, you need an understanding partner. Otherwise, your circle will end up here in this area. Okay, my last 2-3 slides altogether now. Combining everything makes that we're always going back to the 4 P's of pelvic floor problems, and have to realize that peeing, pooping, penetration, and pain, they're all located in and on the pelvic floor. And secondly, they are also all 4 represented in the brain. So pelvic floor physiotherapist, psychologist, that's what we need when we treat male patients with pelvic pain. And that's what we have in our hospital. This is my brilliant hospital, the MCL in Leeuwarden, in the upper part of Holland. We're going to have a fusion, so our name will change starting January next year. So this is a historical slide going to be. But we have it all together in this center, and it's a loving place to work. I started with Leonardo da Vinci, and my